Welcome to our program today. We are talking about thriving with Parkinson's disease. This is a foundational program that we are doing in partnership with our friends from Amneal. And we're going to be covering today what to expect with the disease, some of the symptoms that you might experience, some of the treatment options available to you. And that's not just medications and other treatments, it's also other behavioral lifestyle management things that you can do, how to advocate for yourself, and all of these things to help you improve your quality of life. PMD Alliance likes to offer foundational as well as deep dive programs. And this program that we're doing with our friends with Amneal is just a fantastic foundational program. And we're excited because we feel it's important for you to understand all of those aspects. And we have a fantastic speaker today with Dr. Yasar Torres-Yaghi. Some of you may have recognized him from some other programs that we've had, but if not, I'm excited to introduce you to him. He is a movement disorder specialist at MedStar Georgetown University in Washington, D.C. He is spearheading their initiatives to care for the growing populations of aging patients with neurodegenerative conditions that characterizes overlapping features, both cognitive problems, Parkinson's disease, includes all kinds of movement disorders such as Lewy body dementia, progressive supranuclear palsy, multiple system atrophy, and frontotemporal dementia. So he sees it all, and he's an expert in all of it. So we're so thankful to have him joining us today. I do want you to know that we do want you to ask your questions. So as you go through the program today, feel free to drop those in the chat. At the end of the program, we save some time so we can go through those questions. And I'm going to pass this over to you, Dr. Torres-Yaghi.
Nissa, thank you so much for that warm introduction. Vahid and Lucy, thank you for helping set this up with the wonderful PMD Alliance. I love connecting with all of you, and I love being one of the lucky members of the PMD Alliance doctor team to be able to present virtually to everyone, to talk to everyone exactly what Anissa was talking about, is how it is that we can kind of take care of Parkinson's disease. And I really like this presentation that I'm just sharing right now, because we're going to talk a lot about what to look out for in Parkinson's disease and how to communicate all of that information effectively to your healthcare team, which I think oftentimes is kind of a misstep, is how is it that we can translate what we feel as patients to our healthcare team? How do we communicate effectively so that we can do exactly what the title of this presentation says, is thrive with Parkinson's disease, or thriving with Parkinson's disease? How can we learn more about what to expect and then advocate for ourselves for the best treatment option? Now, this is a promotional presentation. It's an educational presentation. I'm here on behalf of Amneal, but everything we're going to talk about, in fact, is about the condition, and it's educational. But at the same time, we're going to also talk about how it is that we think, as from a clinician standpoint, clinically, how we think about the messages that we receive from our patients. I'm going to give you some information there about how it is that we tease out what on and off is and how we can communicate those episodes so that we can treat them. In fact, we're going to talk about all the treatment options, including the non-pharmacological treatment options, like Anissa was mentioning, that aren't necessarily medicines, but the lifestyle modifications that we can utilize to really take care of this condition. So let's get started. So it wasn't long ago, it was in 2017, when it was about 200 years after James Parkinson first described his cases of Parkinson's disease. Now, as we move even further to 2037, we say right now that there's about 500 to 1 million people diagnosed with Parkinson's disease, but Parkinson's disease is the fastest growing neurologic condition that exists. And so by 2037, I think we're seeing that we may see a doubling or even maybe a tripling in that number, up to 1.64 million people may be diagnosed with Parkinson's disease. They might suffer from both the movement and non-motor symptoms that we see in Parkinson's disease. And as a movement disorder specialist, I tell my students at Georgetown that the bottom line with Parkinson's disease is that it's a dopamine deficiency, and the symptoms are manifested because of that chemical deficiency. So if we can think about it as such, a neurotransmitter or chemical deficiency, we can really think about how we stabilize things, how we maintain that dopaminergic tone. How do we keep those levels of dopamine essentially within that therapeutic window, which I know many of you have heard about, but understanding how it is that we thread the needle as clinicians in terms of medication adjustments and how it is that we think about things can be very helpful. Now, it's true that the average age of diagnosis is around 60 years old. And we think that it happens because of a multitude of reasons, one being a predisposition as a person, as an individual, but then we could be exposed to environmental things that could increase our risk. We know that things like head injury can affect our risk category for developing all neurologic conditions, including Parkinson's. We know that Parkinson's may affect men more than women at a ratio of 3 to 2. So it's important to understand all of these things when it comes to understanding why Parkinson's might happen. In addition to it being the chemical deficiency, it essentially is a circuitry connection problem because of the dopamine deficiency. And that's what we're showing you here. What's happening in Parkinson's disease is, as you see on the left, you see all these yellow dots. That's a lot of dopamine. We have dopamine there. On the right, what we see in Parkinson's disease, and those two circles with lines coming out are neurons. And the way neurons communicate is with chemicals. That's how we transmit electrical information. That's how circuits in our brain and in our body are created, through chemicals. So what we see in Parkinson's disease on the right is that because we have low levels of dopamine, the basal ganglia circuitry, the basal ganglia is the part of the brain that refines movement, is affected, and the circuits aren't properly active because of the low dopamine level. And that manifests as symptoms, clinical symptoms of tremors, rigidity, bradykinesia, which is slowness of movement. Sometimes we can see freezing or difficulty with gait. We can see a shuffling gait, balance impairment, and difficulty with speech and swallowing can happen. Now, everybody's different, so it's important to know that. But there's also the non-motor symptoms. Those are the things that we may not be able to see. Those are the things that we may feel. Things like depression, anxiety, constipation, urinary changes. Pain is an incredibly under-recognized symptom, non-motor symptom of Parkinson's. Of course, when we think about Parkinson's disease, we have to think about it based on the motor and non-motor symptoms. But let's not forget sleep disruption, which can be a non-motor symptom, fatigue, cognitive change or cognitive slowing, feelings of anxiety and agitation. It's important to recognize also that motor and non-motor symptoms may come back, may return in between our regularly scheduled doses of levodopa, and they can those off episodes or those return of symptoms in between our doses might manifest in different ways in each person. It might manifest as an anxiety event at one time, and the next time an off episode happens, maybe it's a tremor and a gait impairment or a combination of things. So it's important to recognize that it's not always the same thing. In fact, it changes and symptoms can vary based on the return of symptoms. Now, the key characteristics of Parkinson's disease include that the symptoms might start off as unilateral in onset. We might see that tremor at rest, that asymmetry may be present in Parkinson's disease. And over time, we say that the condition evolves. And with that evolution of the condition, we have to evolve our medication regimen. And in 2024, I always ask for the participants to mentally promise that they're going to leave the presentation feeling hopeful and optimistic and happier than they did before this presentation. So if you can all give me a head nod that you will feel happier and optimistic after this presentation, because the goal here, even though we're talking about the condition itself and what can go wrong, is to also, for me as a subspecialist in movement disorders and a person who lives and breathes and eats Parkinson's disease, to take care of the condition, to take care of patients, and to improve the clinical research landscape I do a lot of clinical research at Georgetown. I want you all to know that in 2024, there's so many different options to be able to help patients that give us hope. And we'll see a slide at the end of this presentation that talks about hope and the importance of hope in improving our symptoms as well. So remember that in 2024, we might look at a patient with Parkinson's disease and recognize that one person looks very, very different than another person, and they manifest their symptoms in different ways. So it's important to recognize that Parkinson's patients, if you've just seen one patient, you've really only seen one patient. There are some common symptoms that we might see, but the combination of symptoms can differ. It's important, though, however, to recognize that in Parkinson's disease, we're going to work with our doctor and our healthcare team, our physician assistant, our nurse practitioner, our advanced practice provider, everyone as part of the clinical team. We want to do our best in teaching ourselves as patients and teaching ourselves as clinicians. We need to learn from our patients about off episodes, and the patients need to tell us what it is they're dealing with and tell us about their struggles. You see on that third bullet point there that it's important to recognize that our patients have to be on medicine multiple times a day. I wish we had one pill once a day for carbidopa, levodopa, but the way the pharmacokinetics, the way the medicine goes up and down in our bodies, the way we metabolize it and absorb it, our patients need to be on medicine multiple times a day. So it may be important, as that pill burden increases with increased frequency, it may be important to focus on how we can take fewer doses a day, because that can make it so that we adhere more readily to the medicine.
We're going to move into what can happen with on and off with Parkinson's disease, because understanding that our goal is to maintain that dopamine tone, but how do we recognize what's going wrong? What's one of the most important components of this educational series is to understand what off time really is. And I want all of you, if you can, to kind of give me a nod onto, have you heard of all these forms of off? We have on the top left, how many of you have heard of partial on? Partial on means I take my medicine and sometimes I feel 80 or 90% improved, but I take it this time and you know what? I'm partially on. I only feel like a 20, 30% improvement. It's not as active in terms of an improvement that I was expecting. What about on the right there? A dose failure. Where you take your medicine, how many of you have heard about this dose failure concept? You take your medicine, it's like you never took it at all. What happened? Why am I doing everything right and I feel like the symptoms aren't improving? You might have good days and bad days. You might wake up, as you see in the bottom left, you might wake up in the morning and you might say, I don't feel right. I feel like my Parkinson's symptoms are increased. That are my symptoms in the morning are worse than my symptoms in the afternoon or evening. Sometimes patients might experience that, and that's called early morning off. How long is it since our last dose of levodopa in the morning? When was our last dose? The night before, right? And our circadian rhythm, when we wake up in the morning, we open our eyes. What tells our brain to produce dopamine? Light. When you open those window shades and you feel the sun or you turn on the lights, light tells your brain to start producing dopamine. So the morning time, you have so much dopamine. In the evening hours, in the middle of the night, is when dopamine is at its lowest. And that early morning off, because you're at more of a deficit. What about wearing off in general, right? Understanding, if we wrote this down on a piece of paper in a diary form, understanding how long after each dose do I feel good? What's the duration of benefit after each dose? Is it 3-4 hours? Is it predictable? Or is it unpredictable? Can it happen even if I'm taking my medicines on time? Does it happen when I forget to take my medicine? All of those things are important aspects to understanding off time. Now, what does off time feel like? What off time can feel like are basically those motor and non-motor symptoms, right? Tremor, stiffness, slowness, difficulty speaking, trouble with balance on the left. And on the right, we might feel anxiety, agitation, fatigue, pain, sweating, slowness of thinking. Now, off time is not uncommon. In fact, you can see on the left, 90% or so, based on this survey, have at least one off episode per day. About 65% experience off time for at least 2 hours, and greater than 20% of people have more than 4 hours of off time per day. So why is it important to openly communicate all of that information? Guess what? We're going to leave here feeling hopeful because there is so much that can be done to improve things. In this day and age, in 2024, we have so many options. So feeling like we have to live with off time isn't the way we need to live in 2024. So what is dopamine? What is levodopa and how does it work? Well, you take it, you swallow it, and it has to go all the way down your esophagus, past your stomach, past your duodenum, which is the first portion of your small intestine, to your second portion of your small intestine where it gets readily absorbed. Now, I asked a gastroenterology colleague of mine, how far is that from your mouth? When a patient is taking their pills, how long does it take to travel before it even gets absorbed? And you know what the response was? From the pharynx to the jejunum, that second portion of the small intestine, that is a long way. 150 centimeters approximately, perhaps. You know, there's a range there. And what do they say? That's like a football field away. So when we take our medicine, it has to travel all the way down to the jejunum, get absorbed where it might compete with protein. Remember, might compete with foods that have protein in it. Then it enters the blood. And then from the blood, it then has to cross into the brain, where it also can compete with protein. So understanding that once levodopa gets into the brain, it's converted into dopamine. But knowing that it has to go through all those challenging kind of absorption barriers and traveling down, getting the pills where they need to go, it can be challenging. Our goal is to see that levodopa goes up, just like you see, and comes down, up and down. That's our goal in Parkinson's disease, is keep those levels. As you see here, you take one levodopa dose, keep those levels within that therapeutic window. But what happens over time is that window can narrow because we have less neuronal reserve. And our GI system isn't moving the medicines down where they need to go. We have more constipation and decreased motility of the GI system. So the pills we take may not even make it to where they need to go in a reliable fashion before they get absorbed. So that therapeutic window, it gets harder and harder to stay within the zone where people feel good, they're not dyskinetic, but they're also not off. So there are options when it comes to picking our therapeutics for Parkinson's disease to increase that good on time, that time where we're in that therapeutic window, we're not in an off place, and you're not dyskinetic in a troublesome way. What do? Let's think about it. Why does it take a 2-year fellowship after 32 years of schooling to get into movement disorders and become a subspecialist? Why? Because you have to know your medicines. You have to listen. You need your big ears on. You have to sometimes put on your gastroenterology hat, treat constipation. Sometimes you put on your psychiatry hat. You have to treat depression. But when it comes to the nuts and bolts of Parkinson's, you have to know your drugs. Because in 2024, there's so many things that can improve our situation. So what can we do? We can increase the dose or frequency of our immediate release carbidopa levodopa, right? We might go from 3 times a day to 4 times a day, or 5 times a day, or 6 times a day. We might do 3-hour intervals in between rather than 5-hour intervals, right? We can just increase the dose of the medicines we're on, right? Not just carbidopa levodopa, but the other meds. We can add monoamine oxidase B inhibitors. How many of you have heard of the MAO-B inhibitors? Those are things like rasagiline, selegiline, safenamide. How many of you have heard about the adjunctive medicines like COMT inhibitors, COMT inhibitors like entacapone or opicapone? We might add thinking about the dopamine agonist in 2024, we have an injectable subcutaneous rescue medicine. We have an inhaled formulation of a rescue medicine that can be used in between doses of our carbidopa levodopa in case we wear off. We might add amantadine or an amantadine derivative or an adenosine A2A receptor antagonist. Those are medicines that are also utilized that may be helpful to reduce off time and improve on time. So what do we hear about all of this? We hear there's so many different options. There's so many different ways. If we can address what's going wrong, hopefully we can then figure out how to fix it. What's missing from this algorithm? The last but not least option over there on the right, switching to a longer acting carbidopa-levodopa. We have extended release formulation capsules. We have controlled release medicines. We have an extended release formulation of a tablet. The most recent medication is a carbidopa-levodopa extended release in capsule form that was prescribable as of 2015. How long ago was carbidopa-levodopa immediate release, found? When did we start really thinking about it as a treatment option? Cinemat in its form of carbidopa-levodopa immediate release. We learned about it in the 1960s, and it's been reformulated several times since, the newest formulation being the carbidopa-levodopa extended release in Rytary form. So you have immediate release, controlled release, and that extended release over there on the left. Now, it's important to recognize that extended release, it's bundled with multiple ingredients to release medicine rapidly and over an extended period of time. Each version of carbidopa-levodopa contains the same medicine. It's just a different formulation that may last longer in your system based on clinical data. So how do you select and manage your treatments? Number one, we have to make sure that we get on the right medicine and we find the right dose and we find the right frequency. Hopefully, we're able to reduce symptoms, alleviate those symptoms to keep that stability over time. It's important to talk and express yourself to your doctor. We want to hear about the good days, but we also want to hear about the bad days. You want to bring your care partner to the appointment or family to also help us take notes and write things down. In fact, you may want to go prepared so that you can set a treatment goal at the end of each visit. With all of these therapeutics, maybe you can think about communicating effectively with your healthcare team. We might want to start you on a dose, gradually increase the dose of, let's say, carbidopa-levodopa in a formulation to treat the symptoms and find that right dopaminergic tone. Keeping track of your symptoms, using a pen, writing it down. One of the most effective visits I've ever had was basically a manifestation of a picture worth 1,000 words. A patient came in and wrote down 8, 9, 10, all the hours that they're awake. She showed me a good day and a bad day. And she said, on a good day, I see a lot of green check marks, some yellow, and some red. She basically made it like a color-coded day, a diary. And she wrote down when she took her carbidopa-levodopa, and she told me, when it's green, I feel good, I'm on. When it's yellow, I may be wearing off, and when I'm red, I'm in and off episode. So she did it all like that, and she even had purple for dyskinesia. So she had purple, and on a good day, things were mostly green. But on a bad day, in fact, she had more red, more off time, and she had some dyskinesia, more purple. And so she showed me this, and I noticed, I said, well, there's a pattern here. Looks like you're wearing off about 4 hours after each dose. And oftentimes when you eat, you may wear off, and the dyskinesias may be unpredictable. But I was able to think through it, and it was a good, effective tool of how it is that we can talk to our healthcare team and how it was that it was an effective way to communicate with us. So it's important not to forget that we can advocate on our behalf. So if a medicine's no longer working, tell your healthcare team and say, hey, is there a way that I can get more good on time? How do I reduce my off time and improve my good on time? Now, we talked a lot about medicines, but let's not forget lifestyle also matters. What kind of diet is the one that we say is very good for our neurologic health? We say the Mediterranean diet, right? That has to do with things like fibrous foods. You want to think of things like proteins, legumes, beans, olive oil, omega-3 fatty acids, things like seafood that might contain vitamin D, right? You want to make sure that you're utilizing that in your diet. What else is important? Exercise is so important in Parkinson's disease. I think I saw someone doing some exercise. I love it. The more exercise we do, the better. The more brain-derived neural growth factor as we exercise, which is a chemical that helps protect our neurons in our brain cells. What else goes up with exercise? Are the chemicals that make us feel good, endorphins. That makes us feel good. What else happens? We train our brain to not just utilize the Parkinson's circuit, but there are so many circuits that help us move. That's called plasticity. Exercise helps us with plasticity, reinforcing those other parts of the brain that can help us move. So there's science behind why exercise works. What else does exercise do? Helps us sleep better. And if we sleep better, we wake up feeling better. And so when we're well rested, we have more focus and more energy. So improving our overall quality of life, reducing our symptoms are so, so, so important. This is one of my favorite slides. Talks about dopamine, that the medications that we use and that we can consider for ourselves, there are so many things that can be done. Dopamine is the concept developed by Parkinson's disease researchers and doctors that take care of people with Parkinson's disease. That people that have hope in their medicines and with their exercise and had a strong sense of control in their treatment plan would do better with a better quality of life. So it's important to use that concept of dopamine, using medications, ask questions, advocate on our behalf, communicate effectively, try to reach that goal, just like the bridge behind me between Washington, D.C. and Virginia. We want to keep that goal. We want dopamine levels. We want that dopamine and that dopamine, those dopamine levels to keep us within that therapeutic window without the roller coaster ride of Parkinson's. We want to smooth out the peaks, fill in the troughs. We want to make sure that we are trying our best to stay within that sweet spot and know that we are not alone. When we talk about our healthcare team, the healthcare team is there to help. We are always trying to work on defeating Parkinson's. We're doing a lot of research. I'm a very avid researcher, clinical and basic science at Georgetown, and I try to inspire our medical students to go into neurology, to go into movement disorders, to learn about research. There's so much happening in the Parkinson's disease community, and we're all together in this so that we can thrive with Parkinson's disease. So what did we learn today? Now we're nearing the end of this wonderful presentation. Off time is different for everyone, and it can impact our lives very differently. So it's important to talk about it with your healthcare team. As time goes by, Parkinson's disease does evolve. So we have to evolve our regimen to address the needs of the evolving condition. And our goal overall is to maximize good on time without seeing those troublesome dyskinesias and with improving that off time as much as possible, utilizing all the non-pharmacologic measures and the pharmacologic measures, all those different amazing medicines that I listed off, those different classes of drugs that we might use in combination with each other to improve symptoms in the long run. So thank you so much for your attention. I hope everyone, now we get into the Q&A section, is feeling positive and optimistic that we learned a lot today. Hopefully, I know a lot of you, because you're PMD Alliance members, are well versed in what Parkinson's is and what can go on and what it is that we can do to educate ourselves and move the needle forward treatment-wise. Know that Parkinson's disease is ever changing. Parkinson's disease research and medicines continue to come out. Just in the past 5 years, we've continued to see explosions in the therapeutic options for Parkinson's. So I hope everyone's feeling good, and we're ready for our Q&A part.
Thank you so much. I am so excited that you got through that, and I do have a few questions. I want to start off with some general ones. So there was a question that came in. You talked about dopamine, obviously, at the beginning. And this person's wanting to know, are there other neurotransmitters involved with Parkinson's?
Yes, very good question. Right, important question, because as a movement disorder specialist, we do our best with understanding the dopaminergic system, right? Dopamine system. So yes, it's true that we have low dopamine levels. We're dopamine deficient, and our goal is to maintain dopamine. But it's not the only neurotransmitter that's affected. I think that's a very, very important concept. So the bottom line is, it's a combination of chemicals or neurotransmitters that can be affected. Our serotonin system can be affected. Our norepinephrine system, which is our adrenaline norepinephrine system, a lot to do with our sleep-wake cycle. It has a lot to do with not just our sleep-wake cycle, but our mood and our alertness can be, serotonin can be responsible for that. Norepinephrine or adrenaline can affect our blood pressure. Living with lower levels of norepinephrine can make it so that our blood pressure can be low or our energy level can be low. What about acetylcholine? A little bit of cognitive impairment can happen. And so acetylcholine levels, which is a chemical for memory and cognition, can also be low. So there's a multitude of things. The adenosine system is another chemical neurotransmitter. We know that the A2A adenosine receptors increase in our basal ganglia as Parkinson's disease progresses. So it's not just one chemical or neurotransmitter. So it's important to know, guess what? That there's ways to modify and modulate many of those chemical systems. You think about serotonin, we might use medicines that modulate serotonin. There's medicines that replete norepinephrine. There's medicines that augment acetylcholine. So we use all of these medicines in combination, understanding the neurobiology to be able to treat symptoms.
There was another question. Person wants to know, is pain in Parkinson's from faulty brain signals or due to rigidity and dystonia?
Yes. What's the first part of the question, Anissa?
Is pain from faulty brain
pain.
signals?
Okay, thank you. Good question. You know, it's probably multifaceted. In my understanding, pain can be a function of it's not specific. So it could be a function of dystonia and rigidity or stiffness that can happen, which can be painful. But a multitude of things can also be affected. It could be pain signaling in the brain and the spinal cord, especially if we have patients with rigidity, and as we get older, our musculoskeletal system can be affected. We may have things that are affecting our nerves or our spinal cord. We may have trouble with the peripheral nervous system. Things like neuropathy can also happen in Parkinson's disease, and that can create pain. So it's a combination of all those factors.
I guess there's a semi-related question. This person wanting to know, and it's a lot, I think, related to off too, is what's the difference between dyskinesia and dystonia? Does one cause the other? Since we were talking a little bit about pain.
Yeah, good question. So dyskinesia is an uncontrolled movement. So it's an uncontrolled excessive movement that can be dance-like. So a choreiform dyskinesia is one that is more wiggly in nature. We might see it, but there's choreiform dyskinesias, and there's also dystonic dyskinesias, which could be, in fact, it's an excessive movement, but it puts you into a dystonic tone where you're almost frozen in place. You're not moving. It's not an excessive movement. Now that's if it's a dyskinesia. You can also see dystonia as a symptom of being in an off state, right? Dyskinesia is thought about as being at a peak dose state. And an off state, you can also see wearing off dyskinesias, but you can also see dystonia, which essentially manifests itself as stiffness of, we say, agonist and antagonist muscles. It's like the bicep and the triceps do two different things to the arm, but they can both be contracted because of dystonia. And that can lead to conformations of the arm, as an example. Very hard sometimes because it's so painful. And so recognizing if it's a symptom of off is important because it might be very, very manageable if you can target the off time.
Another question, I feel this shaking inside of my body, sort of like a vibration. Is this a tremor?
So it's not uncommon, anecdotally in my clinical experience, to hear a multitude of different ways that our patients describe symptoms. An internal sensation of tremor is something that has been described, but we also have to know sometimes it's a dyskinesia that can feel like an internal sensation of movement. So it's important whenever we feel a symptom like this to figure out, just like in that diary format, so that we can understand, could it be a dyskinesia? Could it be a wearing off? What is it? Is it a tremor? Is it a dyskinesia? Is it dystonia? These are the types of things that are so important. But it's not uncommon for people to experience sensations of tremor, either visible or an internal sensation. Sometimes it's a feeling in their limbs or an internal sensation of their body.
You're mentioning tracking symptoms. This person wanted to know if there's a specific tool that you recommend that's best for tracking symptoms.
Yeah, there's different ways to think about it. We even have ways to track it with our technology, right? With wearables or with phones. But another way of doing it, which is kind of the traditional way, in fact, the way that we think about it in clinical research trials is writing it out. The same way that I kind of gave you an example of my patient who came in and described on an hourly basis a good day and a bad day, understanding when the medicine is given throughout the day, if it's given at 7 or 11 and at what intervals, how long after each dose we feel like we're in an off state. We can even write down information in the middle of the night. Let's not forget, when you wake up in the middle of the night, you may have off time. You might wake up feeling uncomfortable. You might wake up feeling like we have to urinate. That's called nocturia. That could also be a symptom of wearing off. So writing it down, I think, is key in diary format.
Person's wanting to know about dizziness and sort of fuzzy feeling when they stand up, and it might take a minute for it to resolve. Is that a symptom?
That's a non-specific symptom, and I can't speak to the exact case, but in general, when we think about Parkinson's disease in clinic, we have to recognize, that many things can happen to our cardiovascular system. So it could be in cases of people feeling symptoms with standing, hard to describe. Some people might feel lightheaded, like they're going to pass out. That could be low blood pressure. The other thing that can happen with standing is a feeling of imbalance. That could be a symptom of being in an off state or just being under optimized with medicines. The other thing that can happen is actual feeling dizzy, like vertigo-like feelings. That can feel like room spinning. So it's important to tease it out and recognize what is in fact happening, because to a neurologist, kind of thinking about imbalance and dizziness, vertigo, lightheadedness within the context of off time is very, very important. So recognizing that, communicating that information to the healthcare team, because if it's addressed, then if we recognize that in terms of detecting it, then we may be able to treat it if we know what it is.
All right, so this person wants to know, how does one work through debilitating fatigue to exercise?
Fatigue is tough too. Remember, fatigue could be a symptom of wearing off. So kind of understanding if it's an off episode is important. Going back to low blood pressure, fatigue can be a symptom of low blood pressure. So knowing if blood pressure is low as a symptom, remember, that can happen with Parkinson's disease. And then fatigue sometimes has an element of somnolence, feeling sleepy as well. So that could be also something related to poor sleep. Remember, in Parkinson's disease, we have trouble sleeping. We might have sleep apnea. We might act out our dreams. We might be up all night, kind of feeling uncomfortable. We might be up at night, also having trouble with urination. So all of those things will contribute to fatigue. So recognizing, which one of the or if all of those are present, because there's ways to treat each one individually. So you would try to figure it out and determine that. And let's not forget, if fatigue is a symptom of off time, then writing it down and seeing, specifically when it happens is also important.
Okay, this question is, I've been taking Cinemet for over 4 years and my leg cramps have become more frequent and very painful. Is cramping considered downtime, which I think maybe they mean off?
Yeah, sorry to hear that. So yeah, so cramping can be very hard and painful and debilitating. Cramping, doing things like exercise can help with cramping, stretching, hydration is very important, proper nutrition, importance with sleep. Detecting sleep apnea is also important, just generally speaking, with cramping. But it also could be a symptom of neuropathy or wearing off. Wearing off, in fact, can produce a cramping-like sensation. You can have dystonia as a symptom of wearing off, and that can be uncomfortable. So it could be a multitude of things, but determining what's in fact causing the cramping can be helpful.
Can you talk a little bit about dystonia in terms of where all that might affect the body?
Yeah, so dystonia can affect, it can be part of Parkinson's disease, right? So it can affect your head and neck. People can have what's called cervical dystonia, where their neck or spasmodic torticollis can be tilted and the neck muscles can be strong and hypertrophic. Um, Also, you can have dystonia of the trunk muscles of the arm, of the leg. So dystonia can be almost anywhere where the muscles are. Again, treating it and understanding if it exists is important, right? In 2024, what gives us hope, we talked about dopamine, what gives us hope is that we have treatments. So if we determine that dystonia exists, it's not uncommon for us to utilize treatment solutions for that. There's ways to treat it too.
We're getting a message that your network bandwidth is low. You've been reduced a little bit. Okay, so we had a question. They want to know, how do you get your clinician to listen about a treatment that they've researched when they have limited time with their physician or their healthcare provider? So they've listened to something that
Yeah,
maybe was a live stream and they're like, I want to talk to my healthcare provider about this, and they go back to them and say, hey, I've learned about this new medication. Any suggestions on communicating with the healthcare provider?
yes, I'm so sorry about the bandwidth. But yes, it's so important to communicate. So that's part of the presentation today is how do you enter into the clinical room and have an effective meeting with treatment solutions. And what I counsel my patients, I make sure that we do our best of keeping track of our medicine list. Make sure our medicines, we know them. We've written them down. We've updated them. We know when we take them. We know the dose. How many hours in between are we taking carbidopa, levodopa? And then we go in also with something written down with questions and symptoms to communicate effectively, because it's true. There's limited time with the clinical team. So writing down your symptoms, expressing information from the diary is important, but also being able to go in with your questions already written down so you're not thinking through. So you kind of have something to rely on while you're there. All of those things can be important. And then going in with the team, with your own team, with your partner, with your family, or if you go in, make sure that you even write things down, make sure you have things written down at the end of the visit. If it's either produced by the clinical team as patient instructions or written down by you, understanding that because there's a lot of information that might be thrown our way as patients, and writing it down and having it written so as to be able to go back to it is important.
And somebody wanted to know, well, how often should they be seeing their neurologist? Is 2 times a year a typical amount? That's what they're doing.
It varies per patient. Sometimes I ask a patient, when do you want to come back? And they say, tomorrow. And then sometimes I ask the patient, when do you want to come back? They say, I don't want to see you again, doc, but I guess I have to. And so it's very individual for each person. And if people aren't doing as well, sometimes we'll see them more frequently throughout the year. But it all depends on the capacity of the institution or the practice that's seeing you. It depends on the volume of the clinic. But part of this presentation is to talk about advocating for yourself and ask, if we're seeing each other at 6-month intervals, maybe we could ask, maybe could we do more quarterly visits? Is there a way to do that? There might be a way to do it. Say, is it possible to see you in between our 6-month intervals? Maybe, in 8 weeks, and maybe the doctor or healthcare team might say, yes, sure, I can squeeze you in here. But it might be a truncated visit or not. But having that conversation is so important because it's very important to talk about off time. Off time is very, very important, just like we learned today, because there's so many ways to treat it.
Yeah, and I think it's important to continually talk about what off time actually is and how it looks, because it is a confusing concept for some people. And I love how it's broken down and how you viewed it today about the various presentations. And so I think we can have that conversation regularly because it is something that people still get confused about. So thanks for, your willingness to keep going back and kind of explaining all of those concepts.
Absolutely. Thank you for listening, and thank you for all these wonderful questions. Hopefully we all feel that we've been able to learn something and empower ourselves with knowledge about what can go wrong in Parkinson's, but only to remember that we can do things to make it right. That's the goal. There are many solutions to the problems that we can encounter. And I want everyone to know that. We are, as movement disorder specialists, we're optimistic. We have hope in our medicines. We have hope in Hopamine. We have positive feelings about where the field is moving from a research standpoint. In 2024, there's a lot that can be done, and that solution-driven, kind of action-oriented, proactive approach makes a huge difference in Parkinson's disease. It's a huge difference for us, so that we can impact our lives in a positive way, knowing that we exercise, sleep, eat healthy. Having that as non-pharmacological tools also is very important. So please, let's not forget, in Parkinson's disease, so much can be done. So I want everyone to feel good and happy. We learned a lot today. We had a really awesome discussion, and hopefully we leave, when we sign off, we feel good. We say, wow, we learned something, and there's a lot that can be done nowadays, and we'll be more effective now and more able to communicate some of our symptoms to our healthcare team and say, hey, what can I do about it? How do I improve my good on time? Help me. What can I do? We have to advocate. So good job, everybody. Thank you for listening.
Thank you. Thank you so much, Dr. Torres-Yaghi. I am so thankful for your time. I know everyone joining us is as well. And so I'm going to invite them to show their gratitude and appreciation with our wave of gratitude. Thank you so much. And of course, to our Amneal team that's on, thank you so much. This is such a wonderful program, such a great overview. I appreciate everyone's participation today. Hope you have a wonderful day.
Thank you.
Thank you. Bye-bye.